So for something entirely different. So today I'll be talking about dual source photon counting CT, consistency in spectral results at different acquisition modes and heart rates. Heart disease is the leading cause of death for adults in the US. And of those heart diseases, obstructive coronary artery disease is the most prominent. It describes the blockage of coronary arteries as seen here on the left with a plaque. And this plaque can be characterized via imaging techniques. And some of these include non-calcified, as marked by blue arrow, calcified, and mixed. Traditionally, this is evaluated and treated with invasive coronary angiography. But over the years, this has transitioned to CT evaluation. So in general, when it comes to imaging with CT for the heart, it has unique challenges in comparison to other body parts. The reason for this is that the heart is constantly moving, so the motion, this requires high temporal resolution. And in addition to this, imaging with cardiac CT means that you need sufficient Z coverage, so covering the entire heart rather quickly, as well as preserve spatial resolution in order to evaluate small structures like coronary arteries. Now, it's not that surprising that because the heart is constantly moving and that cardiac CT can only reach a certain temporal resolution, that this can result in motion artifacts. And an example of that motion artifact is seen here on the left, where the white arrow points to blurring. Other artifacts include streaking and discontinuities. It's also not surprising that these motion artifacts are affected by the heart rate, as well as the portion of the cardiac cycle in which the image is acquired. So here at the top, we have an ECG, just to demonstrate what the cardiac cycle looks like from an electrical standpoint. The start of this cardiac cycle is at the QRS complex at the R peak. And in a study, they evaluated the effect of both cardiac phase as well as the heart rate, and looked at the images to evaluate whether they had motion artifacts. And so here on the x-axis, we have the cardiac phase, or the portion of the cardiac cycle. And on the y-axis, we have the percent of patients without motion artifacts. Now you can see that for the most part, the motion artifacts are minimized at a phase of about 70%, but this drastically decreases for patients with heart rates over 80 BPM. Now, with single source CT, there are two main modes that are utilized. The first is retrospective low pitch helical, which has a pitch of about ranging from 0.15 to 0.25. And so here a helical scan is taken at a low pitch, and you can see with the ECG with the yellow highlight that the tube is constantly on, but modulated at portions of the cardiac cycle that are deemed not so crucial to be lower. And so you can imagine that this results in a high radiation dose, but in general, this mode allows for a wide range of heart rates, and also allows for retrospective selection when it comes to reconstruction. So in theory, you could reconstruct outside of the desired phase, perhaps at a lower image quality, but you can also exclude data for poor triggering, such as from arrhythmias. The second mode is prospective step and shoot. So we walk away from the helical scan and now we're taking axial scans along the Z coverage. And so this occurs across multiple cycles, as you can see with the ECG here. Unsurprisingly, this reduces radiation dose, but it works only so well for patients with high heart rates. So this is generally used for patients with stable and relatively low heart rates. Now, over the years, CT developments have helped cardiac CT, and one of those is dual source CT. Dual source CT uses an additional tube and detector set, offset about approximately 90 degrees from the other tube and detector. And so this reduces the required rotation for an axial scan from 180 degrees plus fan angle to approximately 90 degrees. And so this doubles the temporal resolution and decreases the amount of motion artifacts associated with higher heart rates, particularly for the single source cardiac modes that I mentioned before. It also enables a new acquisition mode known as prospective high pitch helical, also known as flash. And so now, instead of scanning across multiple cardiac cycles, we're taking a high pitch helical scan. So with a pitch of about 3.2 at a single cardiac phase. And so by doing so, again, this is a drastic reduction in dose in comparison to the spiral and the step and shoot modes, but has much less flexibility when it comes to reconstruction of images. Another development in CT is spectral CT, which utilizes the attenuation from 2 or more spectra in order to improve material quantification and characterization. There are many ways to achieve this, as many people have discussed over the last 2 days, including dual source, rapid KVP switching, spectral detector, and photon counting. Here we're talking about dual source photon counting CT. And you might ask why can't we just do this in dual source if dual source has the capability with higher resolution? And the reason, as Shrey mentioned earlier, is that the dual energy mode with dual source requires the resolution to be reduced back down to the original resolution. And so the addition of photon counting detectors allows for both the advantages from dual source, its temporal resolution, and photon counting in terms of its spectral results. And those spectral results include virtual monogenic images, iodine maps, virtual non-contrast maps, and effective atomic number maps. Some of the advantages associated with spectral CT that are helpful for cardiac CT include reduction of calcium blooming artifacts. So here you can see on the left a conventional image, and on the right a virtual monogenic image at 140 keV, and you can see a drastic difference in the size. The estimated size for this plaque is more closely represented by the virtual monogenic image at 140 keV in comparison to the conventional image. Similarly, for metal artifact reduction, we can use the same theory using higher virtual monogenic images to better characterize the stent, but this also allows for better illumination of the lumen within the stent, allowing for evaluation of in-stent restenosis. For material characterization, we can use iodine density maps to verify whether these are leakages. And last but not least is contrast boosting, where sometimes scans are poorly timed in relation to the bolus of contrast. And so in the conventional image here, the contrast isn't great in relation to the soft tissue, but this can be boosted or salvaged with a virtual monogenic image at a low keV. So in general, dual source photon counting CT allows us to take advantage of the dual source capabilities in terms of temporal resolution for cardiac CT, while the photon counting portion allows for us to take advantage of the spectral results. And so the aim of our study was to evaluate the effect of acquisition mode and heart rate on spectral results. So in order to do this, we have a cardiac motion phantom where we have a simulator that is connected to a bunch of rods. These rods move with the Achenbach motion that's been previously published, and each of these rods represents a coronary artery with different extents of stenosis and different material plaques as represented by the orange boxes. Here we evaluate a stenosis of 50% with a fibrofat plaque. For the image acquisition portion, we use a dual source photon counting CT at 120 kVp at a dose of approximately 10 milligray, and we investigate all 3 modes. So that's dual source spiral, dual source step and shoot, and flash. We also acquire an additional static scan as a ground truth that we later used for comparison and modulated the simulator to 60, 80, and 100 beats per minute. For each of these scans, we acquire the iodine density maps, the virtual monogenic images at 40 keV as well as at 70 keV. So for the analysis portion, we start with the stenosis lumen. So here on the left, we have a coronal view of the rod, and it looks like someone took a bite out of it. And that the portion that is bitten out is the plaque. And so we select the central 5 slices and look at those axial slices. So this is what those axial slices look like for both the static and dynamic scans. We then apply adaptive thresholding to acquire the mask of the stenosis lumen. And by comparing these 2 masks, we then can calculate the dice coefficient. Now for the non-stenosis lumen, instead we look at the eccentricity, so essentially the shape of the rod itself. And so again, we acquire the axial slice, apply adaptive thresholding, and from this mask, we can then extract the contour and its properties to calculate the eccentricity, where the eccentricity of 0 represents a line, and eccentricity of 0 represents a circle, and eccentricity of 1 represents a line. Last but not least is the line profile. So we acquire this in the center of the stenosis once again. And so this line profile looks like this. We then, in order to isolate the peak, we then calculate the mean plus standard deviations for the pixels to the left, the five leftmost pixels and the 5 rightmost pixels. And that threshold is that. And then we calculate the area under the curve, normalized by the height of the peak. So first, starting with the stenosis lumen. So here on the left, we have some example images of the static 60, 80, and 100 beats per minute images of the stenosis lumen. And in general, just visually, it looks quite similar. And this is corroborated by the dice score as seen here on the right, where the x-axis is the combination of the heart rate as well as the spectral results. And the y-axis is the dice score. In general, there's no significant effect of acquisition mode or heart rate for both the iodine density and the virtual monogenic images at 40 keV. And it's worth noting just visually that the high-pitched spiral scans tended to have the best consistency. We can make a similar conclusion for the eccentricity. So here again, we have example images, the static 60, 80, and 100 beats per minute. And then on the right, we have the plot. And generally, this was independent of heart rate and acquisition mode across the different spectral results. You might be asking, why is this important? Well, the fact that the rods aren't changing shape with higher heart rates indicates to us that there is no blurring, or at least minimal blurring. So in general, the shape is rather preserved. Otherwise, we would expect some distortion and some change in size as well. There were some small deviations seen for the 100 beats per minute, and we associate this with motion blurring. Last but not least is the normalized area under the curve. So this metric represents the integrity of the image. So it's both an evaluation of the diameter of the stenosis area, as well as the combination of all the pixels. But we normalize it to remove essentially any variations in contrast. Again, this was not significantly affected by acquisition mode or heart rate for the virtual monogenic images. So in conclusion, we demonstrated that the spectral results for dual source photon counting CT are stable with heart rate and acquisition mode. These spectral results are available now with dual source photon counting CT, and this should be incredibly helpful for patients with higher heart rates. We expect that the additional spectral information will be helpful for clinical characterization of coronary artery disease as well as other heart diseases. And we can see this here in the bottom left, where we have a coronary artery with calcified plaques, and that the virtual monogenic image at a higher keV allows for better illumination of these plaques, as well as the portion of the coronary artery that is not stenosed. And also with dual source photon counting CT, there has been some investigation into high resolution evaluation of these arteries, as seen here on the right, which allows for better separation of smaller calcifications. I'd like to thank my lab for their support, and that is all.
That was a really nice study. So there's a couple of ways to speed up the heart rate. One is to reduce the, say, end diastolic delay. And then the heart kind of beats with the same velocities, just at a higher rate. Does this phantom, when you crank it, does it go faster or does it decrease those delays?
That's a good point. I'm not entirely sure. That's something that we would have to investigate further. From my understanding, I think it just speeds it up.
So the velocity gets higher at every
Yes, the
phase.
velocity gets higher.
Where does it, the curves you have didn't ever go down or break? When you keep turning that dial up, when do the images finally break?
That I don't have an answer to. Apologies.
I guess, nice talk. I guess a similar question is, how long is this phantom stationary for? You have a very fast acquisition. Is it moving during the acquisition?
So it's moving during the acquisition. It's essentially the phantom itself, the simulator is constant. Sorry, the simulator results in the rods constantly moving. And so there's a trigger on the simulator that then triggers the scanner. So these,
So there's not a quiescent phase where it turns around or it stays stationary for a brief.
not really, no.
Okay.
I mean, in the video, it's not quiescent at all.
Yeah.
It just constantly moves.
Thank you.
Any other questions? Okay, let's thank the speaker again.